Of this MCQ session, we shall be discussing some important MCQs related to the subject of cons and endo. So let us begin today's session. Okay. As displayed onto your screens, there are a couple of questions over there. An important list of questions, the important questions that have come into various examinations. Let us start. The question number 1, as displayed onto your screens, is LDF is not useful for. LDF is not useful for. Now, LDF is a standard abbreviation which indicates laser Doppler flowmetry. It is not useful for recently traumatized teeth, teeth with crowns, immature teeth, or teeth restored with thick bases. To answer this question, you should be knowing the advantages and disadvantages of laser Doppler flowmetry. We know that laser Doppler flowmetry is one of the most accurate methods for determining the true vitality of the pulp. So it is basically a vitality test of the pulp. This vitality test would detect the presence of intact blood supply in the pulp organ of the tooth, isn't it? Now, the advantage of this laser Doppler flowmetry is that it can be used in recently traumatized teeth. Teeth that are recently traumatized, okay, are in a state of paresthesia. The nerve sensations are altered. So if we are relying upon pulp sensibility test, which detect the intact nerve fibers of the pulp, then the results would be ambiguous. They would not be predictable. But if we have to determine the true status of the blood supply, even of a recently traumatized tooth, LDF can be successfully used. So it can be used. Coming to option number 2, teeth with full coverage crowns. Now suppose there is a tooth which is covered with a crown. This crown can be either crown, it can be a metal crown, isn't it? It can be a PFM crown, or it can be a full ceramic or metal free crown. We know that the principle of laser Doppler flowmetry is that it uses a laser light that would be reflected by the vascular elements of the dental pulp. Now, if we are using laser light in a full coverage crown, the laser light, that is the helium neon laser that we use for the test, would not penetrate the full coverage crown, whether it is a full ceramic crown, PFM crown, or your metal crown. So if the laser light would not penetrate the crown, it would be reflected back and we get false signals from the gingival tissues, etc. So the disadvantage of laser Doppler flowmetry is that it can be used only on natural tooth structure. Here the natural tooth structure is not available, so we cannot ascertain the vitality status of a pulp in a tooth with full coverage crowns with LDF. So definitely this cannot be used. Option number 3, immature teeth. Immature teeth also we can use LDF successfully. Why we can use LDF successfully? Because LDF determines the vascular status of the pulp and is not dependent upon the nerve fibers of the pulp. We know that in immature teeth, we cannot use testing like electric pulp tester because the A delta fibers are not fully formed in immature teeth, but we can successfully use laser Doppler flowmetry. Teeth restored with thick bases. There may be a tooth. Okay. This is the pulp organ. This is the dentine present, and there is a thick base on which there is a restoration over there. There's a base above the pulp. But even though there is a base over the pulp, the laser light can successfully penetrate the natural tooth structure and reach the pulp and detect whether viable circulation is present on the pulp or not. So definitely teeth restored with thick bases, we can use laser Doppler flowmetry. The question is asking LDF is not useful. It is not useful for teeth with full coverage crowns. So the answer to question number 1 would be option B. Now you can get a question related to this in another way. Means the question can ask you which pulp testing is preferred in a tooth with full coverage crown. and you can get various options, and LDF can be one of the option. So please do not get confused. Although laser Doppler flowmetry is one of the most accurate available methods for detecting pulp vitality, it is not useful in teeth with full coverage crowns. So whenever we encounter teeth with full coverage crowns, irrespective of the type of full coverage crown, the most preferred diagnostic test would be solid carbon dioxide snow in teeth with full coverage crowns. So there are basically two set of questions like this. Solid carbon dioxide, all of you know, is one of the coldest available testing agent. So it is cold enough to penetrate the metal, PFM, or the full ceramic crowns and elicit a response from the pulp. But you should remember that solid carbon dioxide would not detect the true vitality of the pulp. It only detects that there are viable sensory nerve fibers present in the pulp. Okay. So LDF is not useful for teeth with full coverage crowns. Coming over to the question number 2. Pulse oximetry works on Beer-Lambert law, Poiseuille's law, Pascal's law, or Doppler's principle. For this, you should know that pulse oximeter is another pulp vitality test that is based on option 1, that is Beer-Lambert. This is something you have to remember. Beer-Lambert law states that the diffusion of laser is dependent on thickness and constitution of the medium. These are the two factors, thickness and constitution of the medium. What is the medium we are testing? We are testing the pulp, which is present in a tooth. So thickness of the tooth structure and the composition or the constitution of the tooth structure, including the pulp organ, determines how much of the laser light would diffuse or traverse through the medium. This is Beer-Lambert law. So pulse oximeter is a method for determining the pulp vitality. Pulse oximeter, all of you know that it measures blood oxygen saturation. Okay, so it is also a very good diagnostic test, a true pulp vitality diagnostic test. Poiseuille's law, Pascal's law are not related. Doppler's principle is the working principle for laser Doppler flowmetry. The word Doppler is there. Okay, so answer to question number 2 would be pulse oximetry works on Beer-Lambert law. And all of you know that pulse oximeter basically uses two lasers, red and infrared laser. Two lasers are used. The red laser has a wavelength of 640 nanometers and infrared laser has a wavelength of 940 nanometers. All of you must have used pulse oximeter, which has become very common after the onset of COVID. It has become a household appliance that everyone has been measuring the blood oxygen saturation levels. So these blood oxygen saturation levels, okay, they are basically measured with the help of pulse oximeter. Two lights, red and infrared, are fired. It is a clip-on type of device. It is clipped around the tissue of interest. Okay. We know that there is oxyhemoglobin and deoxyhemoglobin present in the blood. And the amount of light coming out on the opposite side is detected by a photo detector. This is the working principle of your pulse oximeter. That is the Beer-Lambert law. So whatever is the thickness of the medium, as well as the constitution of the medium, how much thick the pulp tissue is, what is the constitution means how much of oxyhemoglobin or how much of deoxyhemoglobin is present in the pulp, that would detect how much of the light would actually come out. Now deoxyhemoglobin, it absorbs red light and oxyhemoglobin absorbs more of infrared light. So depending upon how much of the red or the infrared light is coming on the opposite side, it would determine the blood oxygen saturation level, and this physical principle is called Beer-Lambert law. Coming over to question number 3. Tooth sleuth is used to perform pulp vitality testing, caries testing, bite test, or root canal orifice location. Relatively straightforward question, simple one. For that, you should know what is tooth sleuth. Tooth sleuth is basically a plastic device like this. When seen from the top, it looks something like this, handle off, and there's a bed with a central cupped out area. Okay, and basically one cusp of a tooth is placed in this cuspal area and the patient is asked to bite upon it. If there is a small crack is an incomplete fracture of the tooth structure. There is no loss of tooth structure. An incomplete fracture is there that is not visible clinically, and the patient is biting upon it. Pain to the patient on release of pressure. Okay. When the patient bites down, there would be no pain. But when the patient opens up, releases the pressure, there would be microscopic movement of the fracture segment that would cause dentinal tubular fluid movement and stimulation of A delta nerve fibers. So there would be pain upon release of pressure. And this device, tooth sleuth, is used in the bite test for detection of cracks in the tooth. Not the fracture, but for detection of cracks in the tooth. This device is called tooth sleuth. Another similar device is called frac finder. So do not get confused. Frac finder and tooth sleuth are the two type of devices. Both are similar in their anatomy and they are used for detection of fine cracks in the teeth. Coming over to question number 4, as displayed onto your screens. All are true for selective anesthesia testing except. Now, what is selective anesthesia testing? If you remember that the pulp testing can be divided into 3 types. Pulp sensibility test, those rely upon the viable nerve fibers. Pulp vitality test, those rely upon viable blood circulation in the pulp. And there are special tests of the pulp. 4 special tests are principally used. One is the bite test, one is the staining and transillumination test, another is selective anesthesia testing, and the 4th one is formation of test cavity. Okay, so selective anesthesia is a special pulp testing method. This is a special pulp testing method. Now, all are true except the question is asking which is not correct for selective anesthesia testing. Intraligamentary injection is given is true because we know that selective anesthesia is used when the patient complains of pain on one side of the face, but clinically and subjectively it is not discernible in the first go what is the offending arch, whether the pain is coming from a maxillary tooth or a mandibular tooth, we do not know. In such cases, we employ selective anesthesia testing. So basically, intraligamentary injections would be given for individual teeth. Yes. The direction of testing is posterior to anterior in each quadrant. We all know that whatever pulp sensibility tests are used, always they are proceeded from posterior to anterior in all quadrants, whether heat testing, whether cold testing, whether EPT testing, because we have to follow the direction of the anatomic nerve supply of the teeth. Okay, so direction of testing is posterior to anterior in each quadrant is also true. It is useful for identifying the specific tooth. Is it true? And it is useful in identifying the arch, whether the mandibular or the maxillary. It is useful basically in identifying the arch of teeth. Although intraligamentary injections are performed, okay, but they are not useful in identifying a specific tooth in the arch. We'll give posterior superior alveolar nerve block, middle superior, anterior superior like this. If the pain is relieved, one of the maxillary tooth is offending. If not, we'll wait for the anesthesia to take off, then give inferior alveolar nerve block. And if the patient's pain is relieved, then one of the offending tooth is in the mandible of that quadrant. Now, what happens? We are giving intraligamentary injection and expecting that we will be able to identify a specific tooth. But that is not possible because suppose these are the adjacent teeth and there's a lot of cross innervation in the adjacent teeth. So if I am giving intraligamentary injection into this tooth also may be anesthetized because of cross innervation. So the technique of selective anesthesia is not useful in identifying the specific tooth, but it is useful in identifying the arch, whether it is maxillary teeth or a mandibular tooth. Okay. So answer would be option number C. Coming over to question number 5. The clinical pulpal condition that reflects the histologic status of the pulp. Now it is a very good question. The clinical pulpal condition that reflects the histologic status of the tooth means what clinical diagnosis of the pulpal disease can give you an actual picture of the histology of the pulp. Reversible pulpitis. What is reversible pulpitis? Reversible, as the name indicates, the patient complains of pain of short duration from a stimulus, usually a cold stimulus. Couple of seconds the pain is there. But we cannot have any idea about what is the actual histological status of the pulp from this clinical diagnosis. Another clinical diagnosis is asymptomatic irreversible pulpitis. What is asymptomatic irreversible pulpitis? The pulp is irreversibly inflamed, but the patient is not experiencing any symptoms like pain or swelling. Okay, we did quite a number of testing methods like cold testing, EPT testing, and all of them are giving indication that the pulp is irreversibly inflamed. But what is the extent of inflammation? What is the histologic status of the pulp? Again, cannot be found with this clinical diagnosis. Similarly, there is a diagnosis of symptomatic irreversible pulpitis. Symptomatic irreversible pulpitis means the patient complains of spontaneous pain or the patient complains of prolonged pain due to a stimulus. That also gives an indication that the pulp is irreversibly inflamed. But what is the nature of inflammation? What is the extent of inflammation? Whether the pulp has degenerated or not cannot be found out with this clinical diagnosis also. We talk about pulp necrosis. Pulp necrosis is a clinical diagnosis that shows that there is complete pulp degeneration. That pulp has no survival potential, and this clinical diagnosis indicates a histologic status of the pulp. So option D would be the answer to question number 5. I hope all of you understand what is the meaning of the question. The question is asking what clinical diagnosis? All these 4 are clinical diagnoses. Okay, we may say the pulp is reversibly inflamed, the pulp is symptomatic irreversible pulpitis, it is asymptomatic irreversible pulpitis, or it is a case of pulp necrosis. Pulp necrosis means it is totally degenerated pulp, no viable cells and nerve fibers are present, and it requires complete extirpation by way of pulpectomy. So it reflects the histologic status. Option D would be the answer. Okay. Coming over to question number 6. The previously captured images in CR are erased by. Now again, this is a standard abbreviation. You can encounter this abbreviation as such. CR stands for basically computed radiography. Okay. It is the abbreviation of computed radiography. Now, what is computed radiography? Computed radiography has another name called PSP. Okay. Or photo stimulable phosphor. Okay. This is one radiographic method that uses reusable, okay, X-ray plates. PSP methods, okay, photostimulable phosphor. It is one of the radiographic technique that uses reusable X-ray plates. Reusable X-ray plates means we'll take radiograph of a patient, okay, it would be digitized. You'll see a digital signal, and once we have used it, we can erase the images of the former patient and reuse the plate for another patient. So reusable X-ray plates are used in case of this computed radiography. So you have to remember that once we have exposed the plate, we use white light to erase the images from the plate. So whatever images are formed, they are erased with the white light. This is something that you have to remember. Okay, blue, red, green light is not used. The white light is used for erasing the previously captured images in a CR, that is computed radiography of photostimulable phosphor plates. Option A would be the answer. Coming over to question number 7. All are true for DDR except DDR is again direct digital radiography, or another name is radiovisiography, RVG. We know that in the clinical setting, RVG is one of the most frequently used intraoral radiographic technique. So the question is asking all are true except what is incorrect about RVG. Most of the sensors are 12 to 14 bits in depth. Now this is something, a technical aspect of RVGs that you should remember, that this is correct. Bit depth means how many shades of gray are visible on the radiograph. An example is 8-bit means there would be 256 shades of gray visible on the radiograph. We know that X-rays, they are monochromatic images. They are black and white images, monochromatic images, and we are able to identify the pathology and different anatomical and other structures, bones, soft tissues, etc., depending upon their radio density. And greater the number of shades of gray, the greater would be the ability to distinguish one structure from another. So most of the modern RVGs, they are 12 to 14 bit in depth. The image resolution is greater than IOPA. It is true. IOPA is intraoral periapical radiograph. Image resolution means, what is meant by resolution? The ability to see two closely spaced things as distinct on a radiograph. The ability to see. It is just like you can compare it with a magnification shot. Okay, two closely spaced objects are present. How are we able to see them as distinct? They are not overlapped. They are not merged into each other. Is known as resolution. So the limit of resolution of direct digital radiography is definitely greater than IOPA. IOPA has a limit of resolution of 16 line pairs per millimeters, and DDR has up to 22 line pairs per millimeter. Line pairs, LP stands for line pairs. So limit of resolution of and IOPA is 16 line pairs per millimeter. That of a typical RBG system is up to 22 to 24 line pairs per millimeter. Okay. The diagnostic sensitivity is greater than IOPA, and the radiation is 50 to 90% less than IOPA. Diagnostic sensitivity does not directly relate to the resolution capacity. Although with RBG, the image resolution is better, the processing of image is faster, we get immediate image displayed onto the computer screen. But that does not mean that it is better in diagnosing a clinical condition through radiographs as compared to IOPA. In fact, some of the well-processed D and E speed films, conventional radiographic films, which have been processed in standard conditions, have better diagnostic sensitivity as compared to RBG. So this option C is not correct. Radiation is 50 to 90% less than IOPA. Yes, we all know that RBG sensors, whether it is a CCD sensor or a CMOS sensor, requires minimum amount of radiation as compared to your conventional film-based radiographs. So this is definitely one of the most prominent advantage of using RBG or direct digital radiography. So this is also correct. So what is not true for RBG? The diagnostic sensitivity of RBG is not better than our IOP. Option C would be the answer to this question. Okay. Coming over to question number 8. The fast break is a radiographic sign that is diagnostic for. Fast break is a radiographic sign that is diagnostic for VRF. VRF stands for vertical root fracture, canal bifurcation, split tooth, or canal obstruction. Now you should know that what is fast break. Suppose there is a tooth. Okay. Which is visible radiographically like this. This is the root canal system of the tooth that is visible like this. When we see it from above downwards, there is a thick radiolucent canal that is visible on the radiograph. But at a certain point, there is a sudden thinning of the root canal. Okay, we know that the root canals gradually taper from the coronal portion to the apical 1/3 of the root canal. We are seeing radiograph of a tooth on, and examining the radiograph, we see that there is a point where there is a sudden thinning of the root canal. This is known as fast break in the continuity of root canal on the radiograph. Okay, if there is a sudden thinning, a sudden break in the continuity of the root canal, it most commonly indicates that at this point of fast break, the canal is bifurcating or trifurcating, means the canal is dividing into branches. So this is an important radiographic sign that helps the clinician in predicting that at that certain point, the canal is bifurcating or dividing into branches. So canal bifurcation. Answer would be option number B. Coming over to question number 9. All are true for MRONJ except. Now what is MRONJ? You should know that it is medication induced. Okay. Osteonecrosis of the jaw. Medication induced osteonecrosis of the jaw, and it is most commonly associated with bisphosphonates. What are bisphosphonates? Bisphosphonates are a class of drugs which are used to treat certain clinical conditions. Okay, like osteoporosis, Paget's disease, and certain cancers like parathyroidism, etc. Okay. So these bisphosphonates are a very commonly used drugs that can be used in both oral and IV form for the treatment of bone diseases like Paget's disease and osteoporosis management. Now, the question is asking all is true. An important disadvantage of these drugs is that they have a potential of causing osteonecrosis of the jaws. So, mandible is more commonly affected than the maxilla. It is true. The incidence of medication induced, which medication induced? Bisphosphonate induced osteonecrosis is more probable in mandible as compared to maxilla. Bisphosphonates are mainly responsible. We have already seen which medications. Yes, they are mainly responsible. And out of these bisphosphonates, I have told you oral and IV, two routes of administration of bisphosphonates are there. IV is more responsible. Oral is less responsible for osteonecrosis of the jaws. Discontinuing the bisphosphonate may not eliminate the risk of developing hemorrhage. This is an important criteria. Okay, it is also true. Even if the patient is not presently taking any bisphosphonates, the patient can develop osteonecrosis of the jaw if there is a history of bisphosphonate use. So presently the patient may not be on any bisphosphonate medication, but if the patient has a history of using it 2 to 3 years before, okay, then also the possibility of development of osteonecrosis of the jaw is high in such patients. Endodontic surgery can be undertaken. This is not true. Whenever we take history from the patient and the patient gives that currently or previously the patient has taken bisphosphonates, all sorts of traumatic procedures like extraction of the teeth, extraction, dental implants, okay, and endodontic surgery, they are contraindicated. We should not undertake these surgical procedures which are likely to induce osteonecrosis of the jaw. So option D is not correct about medication induced osteonecrosis of the jaw. Other factors that predispose osteonecrosis of the jaw are the sex ratio. Female have a greater incidence of developing this as compared to males. Age, if we talk about greater than 65 years of age, have more probability of developing this. IV medications have a more probability of developing osteonecrosis as compared to oral medications. Okay. This is the important thing about your osteonecrosis of the jaw. And what test is used? C-terminal peptide testing. The details of this test is not required. The testing method is C to determine the probability of developing osteonecrosis is CTX test. C-terminal peptide of collagen fibers. Okay. The clinical diagnostic test that is used for this. Okay. Coming over to question number 10. The drug of choice for the management of endodontic pain in a pregnant patient is. It is a simple question. I think everyone would be able to answer it. Acetaminophen, that is paracetamol. Aspirin, non-steroidal anti-inflammatory drugs, and tramadol. You all know that the safest painkiller and anti-inflammatory drug to be used in the pregnant patient is paracetamol. Okay, so option A would be the answer. If we have to make a choice of antibiotic, then amoxicillin is considered to be one of the safest antibiotic for pregnant females. Amoxicillin. Okay. So option A would be the answer for the management of pain in pregnant patient. Now these set of questions, they are related to the topic of cleaning and shaping that has been covered already with your MD sessions. Question number 11. The helical angle of a file is the angle the cutting edge forms with the long axis of the file, the angle formed by the leading edge of the file and tangent to the radicular wall, angle formed by the leading edge and the radius of the file through the point of contact, the angle formed by the leading edge and the trailing edge. So basically, you should know that if this is a file which has got flutes like this, okay, the blade of a file, this is the long axis of the file, and these are the blades. Okay, the blades of the file, they form an angle with the long axis. This angle is called spiral angle or helical angle. Okay, it is called spiral angle or helical angle. The angle that the blade forms with the long axis. So the angle the cutting edge forms with the long axis of the file is the helical angle. Option A would be the answer. Helical angle is also called spiral angle. Okay. And cutting efficiency of the instrument is inversely proportional to its spiral angle. Cutting efficiency. Smaller the spiral or the helical angle, more efficient that instrument would be in cutting, whether it is a burr or it is a file. Okay. Angle formed by the leading edge and the tangent to the radicular wall. Angle formed by the leading edge and the radius of the file. We see the file in the cross section. Okay. Leading edge and tangent to the radicular wall. Okay. These are different angles. The question is basically asking you about the helical angle of the file. So the helical angle is simple angle between the blade and the long axis. All these angles, they are helical angles. Another name for helical angle is spiral angle. And remember that cutting efficiency is inversely proportional to helical angle. Okay. Smaller, greater the cutting efficiency. Question number 12. The cross-sectional diameter of a file at the first rake angle is called D0, D1, D2 or D16. An endodontic file has a structure like this, and according to the latest ISO norms, at the first rake angle, it is called D0, and at the end of the blades, it is called D16, designated as D1, D2, D3, D4, so on up to D16. Question is asking at the first rake angle or at the tip of the instrument. The first rake angle means at the tip of the instrument. It is D0. Option A. Do not get confused with D1 and D2. Previously, they were designated as D1 and D2 respectively. Okay, but this is no longer followed. This is the current ISO norm designation of the diameters of the file. At the first rake angle means at the tip of the file, it is called D0. Option A would be the answer to this question. Question 13. The nickel titanium alloy exhibits superelastic behavior via. We know that nickel titanium is a special alloy that exhibits property of tape memory and superelasticity. Okay. By temperature induced transformation from initial austenite structure to martensite. Temperature-induced transformation from initial martensite structure to austenite. Okay. Stress-induced transformation from initial austenite to martensite, and stress-induced transformation from initial martensitic form to austenite form. Okay. We all know that austenite form, it is a form of nickel titanium that is present at high temperature and low stress. Okay. And martensite, it is the form of nickel titanium that exists at low temperature and high stress. Isn't it? So, whenever the temperature and the stress changes onto the nickel titanium instrument, it would transform from austenite to martensite and martensite to austenite. The transformation from austenite to martensite gave rise to the property of superelasticity, and the transformation from martensite to austenite gave rise to the property of shape memory. This is something that you should remember. So when the austenite form changes to martensite, it exhibits the formation feature of superelasticity, and vice versa from martensite to austenite, it exhibits the feature of shape memory. Now, temperature-induced austenite to martensite or stress-induced austenite to martensite. Options B and D are ruled out because it is asking about superelastic. B and D are related to the property of shape memory. Now, what is true out of A and C? Both A and C indicate transformation from austenite to martensite, whether temperature-induced or stress-induced. It is temperature-induced transformation from austenite to martensite. Option A would be the answer. And suppose the question is asking the phenomena of shape memory, it would be stress-induced transformation from martensite to austenite. Okay. Option D. This is for phenomena of shape memory. So remember, this is temperature-induced transformation from austenite to martensite for the feature of superelasticity, and this is stress-induced transformation from martensite to austenite for the feature of shape memory. This is how you can answer these questions. Question number 14. The principal factor governing the fracture potential for nickel titanium rotary instruments is. The principal factor governing the fracture potential for nickel titanium instruments is the root canal anatomy, clinician's handling, Max-Padden factor, and manufacturing process and quality. We know that nickel titanium instruments, they have a greater possibility of separation of fracture while usage as compared to stainless steel instruments. And another thing is that these nickel titanium instruments show rarely any signs of clinical failure. There is no distortion. The instrument would look intact. We are using it. Suddenly it fractures without any sign and the instrument is separated. Okay. So there are various factors which are related, like Max-Padden factor. Max-Padden factor is basically the ratio of torque required to fracture the instrument upon working torque. The torque means how much of lateral force is being applied while operating the instrument. So Max-Padden factor of any particular instrument is the ratio of torque required to fracture upon working torque. So greater the Max-Padden factor, safer the instrument. Isn't it? Suppose the torque required to fracture is 4 Newton centimeter and we are working at 2 or less Newton centimeter. The Max-Padden factor is increased and instrument would be less likely to separate. Root canal anatomy, definitely straight root canals, there are less chances of instrument separation, and curved root canal would put more stress on the instrument. There are more chances of instrument separation. Clinicians handling of the to use the rotary nickel titanium instruments have to have a good experience of using the instruments, how this instrument is centered in the root canal, how much of force the brush stroke that we are using. Okay, so clinicians handling is one of the most important factors. And inexperienced clinician, no matter how much is the expedient factor, how much is the manufacturing quality or process of the instrument, would likely to fracture an instrument if the person using it is not experienced. So clinicians handling is the most important factor. Okay, all other factors, A, B, C, and D, all the factors, they influence the fracture potential. None of them is wrong, but the question is asking which is most important. Clinicians handling is most important. So answer to this question would be option B. Question number 15. The twinning effect is seen in cobalt chromium, stainless steel, nickel titanium, white helium. This is something you should remember, that twinning is the change in phase of nickel titanium from one form to another. Whenever the temperature and the stress are varied, it changes from austenite to martensite, martensite to austenite. And this change in form from austenite to martensite and vice versa is called twinning. Okay, the process of phase change in nickel titanium is called twinning. So answer is option C. Question number 16. The group 1 rotary nickel titanium instruments are characterized by, all of you know that there are 5 generations of nickel titanium instruments. The group 1 instruments, they are passive preparation with radial lens, passive preparation without radial lens, active cutting with triangular cross section, and special cases. See, option A and B can be the answer, but option A is the answer. They are the passive instruments with radial lens. They have instruments with cross section like this. Okay. Sometimes they are called U-shape cross section. The first generation of nickel titanium group 1 rotary nickel titanium instruments, U-shape in cross section. And they have got thick blades with radial lens. A radial lens means there are flattened spaces that do not allow the blade to actively engage the wall of the root canal. So they are basically passive cutting with radial lens, and they have a typical U-shaped cross section. Example of first generation or group 1 rotary nickel titanium instruments are light speed, profile, and GT file. 3 prominent examples of first generation. Active cutting with triangular cross section, they are second generation group 2. Special cases 3, 4, and 5. Okay. So question is asking about this. So they would be passive preparation with radial lens. Option A is the answer here. Question number 17. All of the following contribute to the efficacy of ultrasonic irrigation except. All of the following contribute to the efficacy of ultrasonic irrigation except eddy flow, shear stress, temperature, and cavitation. We all know that ultrasonic irrigation is mostly done with ultrasonic instruments. An instrument is suspended into the root canal. It is filled with irrigant. Irrigant most commonly used is sodium hypochlorite for ultrasonic activation and agitation. This is an ultrasonic handpiece that operates at the frequency of 25 to 30 kilohertz. Operates at the frequency of 25 to 30 kilohertz. Now, we all know that whenever ultrasonic instruments vibrate, there is increase of temperature. A file is suspended and vibrated ultrasonically, the temperature would increase, and that increase of temperature increases the efficiency of sodium hypochlorite. Okay, so the sodium hypochlorite efficiency is increased due to increase of temperature. And why the temperature increases? Due to ultrasonic vibration. So temperature definitely contributes to the efficacy. Shear stress. We know that the file is suspended into an irrigant, that is sodium hypochlorite. This irrigant has got a surface tension. Okay, whenever it vibrates, there would be generation of tangential stress because of surface tension. So shear stress also contributes to the efficacy. Eddy flow. What is eddy flow? If this is a file, when it is vibrated, there is generation of intense circular currents. There is generation of intense circular currents. The streaming of the liquid takes place intensely around the file that contributes to the efficacy of flushing action of removal of debris. So definitely this is called eddy flow. Eddy flow or eddy currents. Cavitation is the phenomena of formation and bursting of bubbles. So whenever an instrument is suspended and it is vibrated ultrasonically in a liquid, there would be generation of bubbles and bursting of bubbles, releasing energy. That would release the energy through implosion. So this is known as cavitation. So the phenomenon of cavitation may be there, but the efficacy in removing the debris from the root canal is not proven. So D would be the most suitable answer. All of them, A, B, and C, they contribute to the efficacy of ultrasonic irrigation. Okay, cavitation, I am not saying does not occur, but the evidence that it contributes to increasing the efficiency of irrigation is not conclusive. So it is least likely to contribute to the cleaning efficacy. Option D would be the answer. Next question, question number 18. The multiple frequency apex locators are first generation, second generation, third, and fourth generation. This is a question related to electronic apex locators. We know that the generations of apex locators, the first generation, they are called resistance based. They measure the resistance to the flow of current. Second generation, they are called impedance based. Okay. The third generation, they are called comparative impedance based or ratio based or multiple frequency based. These are the different names for the third generation of electronic apex locators. And the fourth generation, they split impedance. Impedance is a physical property which consists of two parts, resistance and capacitance. Okay, and these fourth generation also work on multiple frequency. Means they would send current of multiple frequency, and at each frequency of current, instead of directly measuring the impedance, they would split impedance into resistance and capacitance. So you are left with options C and D. Question is asking multiple frequency apex locators are. Now what to choose? If you have options like this, third generation would be the best possible answer for this, option C. Typically speaking, the multiple frequency apex locators are the third generations. If suppose the same question is there, but third generation is not there in the options, then the second best possible answer would be fourth generation. So this is the first answer of choice. This is the second answer of choice in naming the electronic apex locators based upon the generations. So please do not get confused. If both third and fourth generations, third generation is preferred answer, option C. Question number 19. To establish a glide path before using rotary instruments. You all know that in the sequence of root canal preparation, we first use small hand instruments, and before insertion of the rotary instruments, hand instruments are used to prepare a smooth path to the apical terminus. That is called glide path. Now what is gliding? Glide is an English word that is used in various contexts. Gliding means smooth sailing. So we need to create a path for the rotary instruments from the orifice to the apical foramen that is a relatively smooth and straight path. So to make a glide path, we use a small straight file to create a glide path. This is something you have to remember. A small K file like number 10 or number 15 K file is used. That is not pre-curved. Okay, it is not asking you about negotiation, initial negotiation. Okay, for initial negotiation, we pre-curve the files to simulate the root canal anatomy. But for forming a glide path so that the rotary instrument goes smoothly to the apical terminus, we use a straight small file, not a pre-curved file. Option D would be the answer for glide path preparation. It is not for the initial negotiation or scouting of the root canals. It is for glide path. It is a smooth and straight path for a rotary file to be used subsequently. Question number 20. The canal preparation technique that relies purely on rotary motion is. Now, this is a simple question. All can answer. The canal preparation technique that relies purely on rotary motion is step down? No. Balanced force? Yes. Double flare? No. Crown down pressureless? No. In balanced force technique, we know that the root canal is prepared with clockwise and counterclockwise motions only. There is no typical pulling and rasping or filing motion. We insert the file, rotate it clockwise 90 degrees, then counterclockwise 270 degrees, then again clockwise 90 degrees, and then counterclockwise 270 degrees. So there is only rotation of the file clockwise and counterclockwise in the balanced force technique. And finally, when we have reached the apical 1/3 of the root canal, we would remove it not by pulling out, but by a long clockwise turn. By a long clockwise turn, the file is removed. Okay, by a long clockwise turn. So only purely rotary motions are used in balanced force technique. This long clockwise turn, it is used for file retrieval. Okay. Balanced force technique. Last question for today's session. Question number 21. For adequate apical flushing, the canal should be enlarged to at least what size? Apical flushing means a successful irrigation of apical 1/3 of the root canal. How much should be the apical's preparation size at least? 15 to 20, 20 to 30, 30 to 40, or 40 to 50. Now, how to answer such question? It is asking you about needle irrigation of the root canals. We are inserting a needle and putting the irrigate solution. We know that the apical 1/3 is the most crucial part of the root canal. It should be thoroughly cleaned by flushing with an irrigant. Now, how much the needle would penetrate depends upon the gauge of needle. And the smallest gauge of needle that is available is number 30 gauge, which has a diameter of 0.30 millimeter to 0.33 millimeter, the diameter. So to insert this diameter needle, 0.3 to 0.33 millimeter to the apical 1/3 of the root canal, we need that the root canal is enlarged to size 30 to 40. Why? Because we know that size 35 has an apical diameter of 0.3 millimeters. Size 45 has an apical diameter of 0.4 millimeter. So if we enlarge the canal to 0.3 to 0.4 millimeter, we would be able to insert the smallest irrigation needle available, that is 30 gauge needle, to the apical 1/3 of the root canal. Why it is important to insert it to the apical 1/3? We can place the needle in the conal 1/3 and then flush it. No, because if we place the needle in the conal 1/3 or middle 1/3, the irrigant would seep only 1 to 1.5 millimeter beyond needle tip. It would not reach the apical 1/3. So for successful flushing of the apical 1/3, it is prudent, it is required that the needle itself should be present in the apical 1/3. And for that, we have to enlarge to at least 0.3 to 0.4 millimeter, that is size 30 to 40 K file. So option C is the best answer over here. I hope you understand what is the meaning of the question and how do we answer. Because the smallest gauge of the needle available for irrigation is 30 gauge. This is the smallest needle itself with a diameter of 0.3 to 0.33 millimeters. Okay. Okay, there is one more question for today's session listed over here. Let us take this up. What is question number 22? Melton's solution. Melton's solution is basically a concentration of sodium hypochlorite solution that is used for flushing of the root canals. And you have to remember that 1% sodium hypochlorite is Melton's solution. 0.5% sodium hypochlorite is Aitken's solution. 0.5% is Aitken's solution and 1% is Melton solution. So answer would be option B. For endodontic irrigation, we use 0.5 to 6% sodium hypochlorite for endodontic irrigation. These are the range of concentration that is used for flushing of the root canal. 0.5% is Aitken's solution and 1% is Melton's solution. Name of the persons who first used these solutions. This Aitken solution was first used by Aitken, okay, during World War II for washing the wounds of soldiers. It was not used for endodontic irrigation initially. That's why it was called Aitken's solution. For washing the wounds of soldiers, we know that it is a potent antimicrobial solution. So 0.5 Aitken's and 1% Melton's solution. With this, I conclude today's MCQ session. Thank you very much for being connected with me. Happy studying till then. See you in the next session. Till then, goodbye from my side. Thank you very much. Good night, everyone.